at the public health level, to get us out of this uh, crisis. First lecture, I focused on diagnostics test, and second lecture, which is past week, I focused on the serology, antibody detection, and vaccination um, development. So today will be the most focused on the mass test or public health, and versus the other two focus more on individual health. So first, we all know that 7 p.m. in New York, there's a daily shout out, and I want to at this 8:20 p.m. I want to have a daily shout out to you guys, doctors. We love you. We love everything that you are doing, and then um, please continue to doing what you have been doing, and you have our support. So here I that is by Tony. He's how to get us.
Dr. Han, your voice is breaking up. I can't hear you.
Oh, can you see the screen? I don't think so.
Yeah, now I can see it. Yeah. Now I can
Okay, okay. That. And also, here's another clip that is for the same topic. I hope I can find a button to share the screen, which is by the very King's Hospital. That
I can't hear you, Dr. Han.
sorry,
Oh, now I can hear. I think it's just.
right now you can see the video clip.
I see your screen right now. Yeah, but I can't hear the video, the audio on that video. So.
I apologize. Okay, so okay, somehow it's edited, but I was worried. Okay, so I borrowed these clips just because I'm not a singer, I'm not a composer. I just want to get the spirit out. So our clan, and thank you so much for everything that you have done, saving our life and continue to save our life. So moving on to the background. It's been 6 months, and then how are we doing now? Well, depends on who are you asking and how we're going from. And two, the good news is that Bill Gates was my hero who predicted pandemic back in 2017 and now has resigned all his duties from Microsoft to focus on the pandemic. So he is really my hero. He said, one way or the other, we will be out of this pandemic at end of 2021. So which means 12 months from now. What he said refers to globally. Globally, the developing country as well as the development country. So how can that happen? It's by first, people are aware and then take the precaution. Second, the virus is less lethal than it was before. And third, by herd immunity. Fourth, by vaccination, development, and then execution. So that's the good news. And then, okay, continue Oh, excuse me. Okay, sorry. So continue with the good news is that New York State is doing fine considering where we were at the center of a hot zone. So we have had a consistently low infection, meaning 0.8% or less than 1% for the past 2 months or so now. So we are doing pretty good. And then the hospital beds are almost empty for COVID's sake. And then the other good news is that there are 3 vaccines that has reached clinical trial, third phase. At the third phase of clinical trial, of course, there are hundreds of them in various phases of clinical trials. And then the date of the trial ending will be June 2020. So if they are successful, or one of them are, within 3 days, the vaccine will be conducted to people. And first priority, of course, which is healthcare worker like you guys. All right, moving on to bad news now. As of today, yesterday, I would just say, over the weekend, the CDC director issued new warning saying that, well, Americans, please do not take it easy because at this moment, less than 10% of Americans had antibodies as of July. So this is what study found. So as a former CDC director, Tom Friedman says, there's still a long way ahead and we must adapt. So that leads to my question of how to adapt. I want to squeeze in this interesting topic, COVID in HIV, borrowed from the chief of infectious disease in Cornell University, who just gave us a recent update on COVID and HIV topic last week. The reason I bring it up is that there are some very, very interesting findings, which is contrary to our belief of COVID and HIV in HIV patients. As we know that globally, there are 20 million HIV patients or patients living with HIV. And they are mostly diagnosed in early 80, late 80 and early 90s. So since their diagnosis, they have been living decent. And this is the study that has 39,000 patients that with the 39,000 participants and matched with 387,000 normal people. So after age of 21, their life expectancy are only 5-year difference as of 2015, meaning that if you are HIV positive, you only have you have a chance to live 5 years less than a normal person. And we know normal person's average age of life is around 78 to 84. So they can live almost close to that. That compared to the 2000, there's a 20-year age gap. However, with patients who have comorbidity, then that's a different story. So, you know that HIV has been immunocompromised. HIV patients are on antiviral therapy all lifelong, so their immune system is severely compromised. And so that makes them prone to all sorts of comorbidity. So if they do have the comorbidity, then their life expectancy is much, much shorter due to this comorbidity, not due to HIV itself. And this is due to HIV, but this Can you see my mouse moving? Hi. Okay.
I can't see the mouse.
This is yours, Maya?
This one.
Okay. So sorry of interrupting you. I appreciate the feedback. Yeah, all these Zoom are new to us. So, so dear,
Is your, I can see, is it your presentation? Your screen is not on the presentation, it's on the YouTube right now.
I got it. Thank you. That is important. I wasn't aware. Thank you so much. All right. I appreciate it. Now I am back on, right?
Yes. No, yes.
Okay, okay. I apologize. Okay. So HIV patients, reviewing again, HIV patients with HIV positive, HIV negative, they are expected to live a similar long, healthy life. This is what this graph says. The second graph, and then the bottom two lines are meaning that HIV with the comorbidity, they have a much less life expectancy, but so is the normal people with the comorbidity. So in a way that if a person with HIV dies early, it's mostly due to the comorbidity. So is the same with the non-HIV patient or normal patients, let's put it this way. In conclusion, HIV patients, if he dies at this time, it is due to comorbidity. It is not due to like heart disease, diabetics, cancer, etc., etc. It's not because he's dying from the HIV itself. So I just want you to know about it. In conclusion, they live a very healthy life, even that they have to be on immunocompromised treatment all their life. So the reason I bring this up is because, number one, all the COVID specialty physicians are all HIV physicians. Anthony Fauci is a great example. And second, there was a big concern that HIV patients who are immunosuppressed, everyone is, for the last 20, 30 decades. So they are immunosuppressed, so, which means they are prone to infection. So people are expecting that, they are living with other people. They are not super wealthy who can afford a mansion of their own. So there has been a big concern that the COVID will take a huge hit on these patients, and then there will be double intake, there will be double uptick on their deaths and comorbidity, et cetera, related to COVID. So this study, just the veterans admin cohort study just studies that. It has a large sample size, 30,000 with HIV, and then 76,000 without HIV. And then the people who seek test for COVID is 4.8% versus 3.6%. Well, it is not surprising that HIV patients are extra careful about their own body, so they go and do more tests than the general population. So there is a statistical difference. However, in terms of the positive rate, it's 0.6 in HIV patients and 0.5 in non-HIV patients. They don't really reach statistical difference. So even that they seek test more, they don't necessarily get infected. bear in mind that they are immunocompromised already. So they should, theoretically, according to medical school, but they are not. And then for those who tested positive and developed symptoms, their ICU admission, intubation, and their deaths have not reached significant difference compared to the general population. So in conclusion, contrary to people's belief, including the infectious disease specialty doctors' belief, there is no difference in the COVID infection or complication rates for HIV patients compared to general. So this study has a large sample, but there are many other studies who has much less sample, but they all reached the conclusion. And I am not going to go further. There's South Africa Western Cape study, which has large sample size. And then there is this other studies that all conclude similarly. So the big question is, why? Why did it happen? We were expecting a double intake in terms of virus. They are both both virus attack, meaning COVID and HIV, attack the host similarly by CD4, and they replicate similarly, and also the attack to the body. The symptom of the body is not only due to the virus, but also due to the host response. So the answer is, well, first, we don't know yet. We have to understand as time goes by. We understand HIV very well, but we don't understand the COVID yet as well. But second, there is this, there has been suspicion that the antiviral therapy in HIV, for example, remdesivir, which is one of the emergently authorized drug for COVID, protects both. And every single HIV patient, not without exception, has been on antivirus therapy, remdesivir or alike, for the past however many decades that they have. So this may play a fact that they already have been protected in terms of viral therapy. Even that their immune system is weak, they still do not get the disease. So this is what we do know, but let's see. More research needs to be done, and this is a very interesting topic as well. Okay, so moving on to COVID itself. Here's a recap of the past few lectures. I heard that some of the residents would like to go over the board exam statistical part, meaning sensitivity, specificity, and ROC curve. So sensitivity identifies those with the disease, and specificity on the right-hand side identifies those people without the disease. So the true positive sensitivity is a notion, and then versus in specificity, it's the true negative specificity. And then in terms of sensitivity, there is this false negative notion. And then in terms of specificity, there's this false positive. So I want you to know that two of them apply to sensitivity and two of them applies to specificity. And the nature of sensitivity of a test is that it's related to ability of the test to identify affected individuals, and versus the specificity is to identify non-affected individuals. So the sensitivity is an intrinsic test of itself, and what factors influence it? Yes, antigen characteristics influence, and no, characters of non-infected persons do not influence it, and the prevalence of disease do not influence it itself. So it is an intrinsic measurement of the test itself, regardless of affected, non-affected person, regardless of the prevalence of the disease. And in COVID specific setting, we generally do not talk about specificity at all. So moving on to ROC curve. So here are two cases for a sick person with the dark blue, and then the well person with the light green. The cutoff should ideally be here, meaning on the right is the sick person, and then on the left it's the well person. But in reality, there's always a range, so that there are some overlaps, hence brings the false positive, false negative, true negative, true positive, etc. So there is this overlap area in any test. And this overlapping area is also a moving target. So ROC curve simply captures the continuous flow of this moving target and then plot them out. So each of the static distribution of these two curves is a dot here. So imagine that when it's shifting from left to right, which is depicted on the right panel graph here, each of this dot represent one of part. And then each of these, this is called a receiver operative curve or ROC curve. So it captures a moving scenario of these test cutoff points. And then one step further is that to evaluate one test versus the other, we have this area under curve, which is evaluating how well a test performs. The dotted line is 50%, which means the value of test is a flipping of coin. It's 50%, 50-50. So the higher this area under curve, or the more towards the upper left side this ROC curve is plotting, the better. It's on the x side, it's false positive rate, and then on the y-axis side is the true positive rate. So this orange test, orange ROC curve, this test performs better than this green curve, which further performs better than this dark red curve. So enough of the statistics. Here I want to recap of the first two sessions. The session number 1, we focused on diagnostic test, and then session number 2, we focused on serology test. So we talked about what is the sensitivity. And then for part 1, I talked about sensitivity of the test, diagnostics test, and then the test frequency of diagnostics, and test results turnaround time, CT value, and R naught. This is called R naught with the subscript 0, which is a measure of reduction of viral load test. So, so far there has been 193 COVID tests that has been approved by FDA emergency authorization, and 158 of them are diagnostic tests, PCR and nucleic acid. They all have great sensitivity, but the easy of use and the cost goes from this line, from the left to the right. And of course, the most expensive and then the longer runaround and the gold standard is RT-PCR versus the laminar flow, which is the least sensitive, but also quicker to perform and very, very cheap, is on the far right side. They all have a relatively good sensitivity. And we talked about that the trade-off of turnaround time and sensitivity. And we conclude that for the COVID surveillance test, the effectiveness is compromised by delay in reporting. 2 days of delay will miss the 32% of infectiousness, and 4 days of delay will miss 80% of the cases compared to the 15-minute turnaround time. And then I think it's, at this moment, it's more than 2 days of delay. And also, the test frequency weighs a lot as well. If you test daily, then there is no transmission whatsoever, versus 3 days, there are some, versus weekly. If you test 14 days, that's not doing so much at all. And then these trends perform similarly, whether this is a RT-PCR sensitive test or a 15-minute quick diagnostic test, which is not sensitive at all. So, but is sensitive test not needed? No, not at all. In terms of the hospital setting, high risk settings, when you have to decide that this patient should go on surgery or not, and is the doctors, is he going to expose the doctors during the surgery, you really, really need a very sensitive test like RT-PCR. So, but I just want to emphasize that COVID, it's not a normal disease. At this moment, we are facing the public health crisis. So a lot of the talk has been focused on the public health part, but not to undermine the importance of a sensitive test in the hospital settings. So I just want to bear in mind. And of course, thank you for you guys to even put your life on risk, at least in the March. None of us do know what will happen. And then this CT value, which is cycle threshold value, is the standard for viral load detection. It is the opposite of viral load, meaning that the higher viral load, the smaller CT value. So the smaller viral load, it takes more cycle for the RT-PCR to amplify to enough signals to be detected. So higher CT value, the less viral load. So normally the cutoff is at 33. Moving on to the antibody. So contrary to what medical school has told us in terms of all the virus, for COVID, the IgG and IgM start to develop at the same time, which is quite unique. We don't know why yet. And then I just want you to know, but the similar time at least. There are some saying exactly same, some saying a few days apart. But um, normally speaking, it is within 24 hours that you can detect both IgM and IgG. So in theory, which is in the medical school's textbook, they should have at least a 7-day gap, but COVID do not have. And also bear in mind that due to these antibody developing time and also persistent time, your chance of catching it as well as the chance of not catching it falls into these windows. So the test positivity really depends on the timing of the test. They are, as I said before, they are pretty, all of them are sensitive enough. So the timing is really, really the deciding part rather than the sensitivity of the test. As a medical physician, how much is your likelihood to encounter patients with COVID? This was in August. So you would, for the patients, any patients who walk to your store, walk to your hospital, there are 7% among symptomatic patients and 0.88% among asymptomatic patients who are COVID positive, which is the good news for you is that it's similar to the general population as if you walk into a grocery store. So it's not an increased higher risk of your exposure, possibly due to various reasons, but you still have to take great precaution. That is probably a result of your great precaution as well. We talked about herd immunity. As CDC director said, less than 10% of the general population in US has antibody, but in New York, that rate is much, much higher. In Brooklyn, in early June, the survey says 1 in 4 people in the community had antibody. As time goes by, that this positivity rate has reached almost 50%. So that is the herd immunity in New York City at this moment, so which significantly reduce the transmissibility. We talked about this already. So focusing on today's, I want to, we touched base the individual versus mass testing. Today, I want to introduce a few novel topics or novel techniques. We all know that we have had a tremendous amount of tests performed already. So what can we do more to improve or upscale that test? Well, that lies in the new technology. At this moment, 99% of the tests are performed in private laboratory and only 1% in public. And the reminder of this COVID structure. It has a spike protein, which leads to antigen test, and then it has a core that leads mRNA, RNA core, which can be reversely transcribed to cDNA and then perform this real-time RT-PCR. But there are other types of PCR amplification, which is paper-based and nanopore target sequencing that is not as widely known. I just want to introduce this topic to you. And then this is the new technology, CRISP-based test, Sherlock and detector. This is one step versus two step. So it is RNA-guided DNA lays, whichever it is. And the University of Maryland under Johns Hopkins has been performing 15 tests per week under this new technology. It's not available in New York yet. And then next generation sequencing. There has been these notions on, is this reinfection? And then if I have antibody, am I protective? How long does it last, et cetera, all these unknowns. And then also, are you really testing the immunity to COVID or flu, as the flu season is coming? So the next generation sequencing is on the way. It also, that's to detect different antigen. And the second goal for this generation, next generation sequencing is pooling. So sometimes it's purposeful pooling, like you pool 100 patients' saliva together. Sometimes it is unconscious pooling, which you are detecting you in your saliva, you have COVID and flu or any other vaccine that has been tested positive. So, but on the other hand, I just heard that as the flu season's coming, there is, the FDA has authorized a combined test that can test both flu and COVID in one kit, and it give you results, differentiated results. This is what I just heard. You guys are in the field, so knows much more than I do. And I'll, so again, in terms of COVID testing, the objective of testing for individual is needed to be sensitive enough. But on the other hand, for the public health setting, it is really not as needed. And we don't need to spend that much amount of money, resource into investment, because the turnaround time is quicker, and then feasibility is much more important to get us out of the pandemic. I'm not going to talk into detail about the sensitivity difference in terms of different molecular test form. The take-home message is that they are all pretty sensitive, and then the CT value is only comparable within the same company, so they are not necessarily comparable within each other. And the consensus is CT value should lie below 33. Here, there's from 23 to 37, or even to 40. 40 is overkill. By the times of the 40th amplification, anything can be positive. So you're picking up too many false positives here. So among the emergency authorized tests, only 33 of them are antibody tests out of the total of 193. Majority of them are diagnostic tests. And here is the turnaround. Here is a 2D plot of the turnaround time and the sensitivity. So as I said before, 15-minute turnaround time, even that we lose sensitivity, but we need it for the public health setting to get us at this stage. So a review of the COVID viral load and host response. I said before, the IgG and IgM come out at the same time at week 1. So after symptoms start in week 1, and they peak at week 3, and then persistent for a long time. So the consensus is that 1 month or 28 days, 90% of the people will be seroconverted. So that is the time period for the vaccine administration. As you know, that most of vaccine at this moment need 2 doses, and the recommended gap time between the 2 doses is exactly 28 days for most of the companies. And then in terms of the viral load, they have an incubation time of 5 days, ranging from 2 to 14 days. And then the symptom will last around 12 days. And then the seroconversion will be 5 to 10 days after the symptom. So the transmissibility is in here, both before they have the symptom and after the start of the symptoms. So by the time they got into the ICU and being on the ventilator, the damage is mostly by their own immune response. And their viral load is actually very, very low, to a point that it's almost not transmissible. So, which is retrospectively not so bad news for the healthcare worker. So in terms of where do you get the sample? Well, the nasopharyngeal is the most sensitive. But it takes a lot of sputum or nasal swab. People really, really hate that. So as a trade-off, saliva is as good. So people has been focusing on saliva, and then the next few slides are comparing the saliva with the sputum. And in the blood, it's not good at all. You can never detect virus in the blood. Surprisingly, stool is a great source, not that many people know of, but stool is a great source for virus detection, and the urine not detectable. So I just want you to know that sputum is the best, but actually stool is as good. But due to the practical reasons, nasal swab is widely used. So this is saliva superior. These a few tests. These next few slides talking about the comparison of saliva to nasal swab. The conclusion is that they are comparable, and both in terms of timing, sensitivity, and verified by the virus culture. So they are comparable. And as I said before in the first lecture, there's this newly approved kit that can mail to patients' home I let them collect their own sample, and which turn out to be as good as the collection by a healthcare worker. So that can be a great way. It's 9:04 now. I want to thank you all for coming so early and then stay for the lecture. I really appreciate everything that you have done for us, for the society. Without you, we wouldn't have known any of this at all. So thank you and shout out to you. Anytime, any questions?
So,
Thank you very much, Dr. Han.
Okay. Thank you. Thank you for attending. I really appreciate it. And Aloy, Moyed, you are
yeah,
the coordinator.
yeah. Thank you very much.
Special thanks to you. You
Thank you.
made everything so seamlessly,
No problem. Thank you. Thank
very
you.
accommodating.
Thank
Uh,
you.
7 o'clock in the morning. I really, really appreciate it.
No problem. Thank you very much.
Absolutely.
Good.
Okay. And wish you a great week.
Thanks.